So I see we have some people already joining. Welcome to the webinar. And just wanted to say we're going to wait a couple of minutes to give people a chance to log in, and then we'll get started. I think we'll give one more minute to allow people to join, and we'll start up. Welcome, everyone, to the second of IVI's 3 webinars on equity. Today, we're going to be talking about methods in value assessment that could support equity and equity considerations. And we'll start in a few minutes. I'll set the stage, but first I'll introduce our speakers today. We have a great panel. Speaking first, we have Lisa Prosser. She is the director of the Susan B. Meister Child Health Evaluation and Research Center at the University of Michigan. Her research focuses on measuring the value of childhood health interventions using decision sciences, and she's currently focusing on newborn screening programs, vaccination programs, and methods for valuing family spillover effects of illness, a very important gap in our field. Her research in vaccine program cost effectiveness has been used in setting national vaccine policies. Following Lisa, we'll hear from Stacy Kowal, who's the principal researcher in health policy and systems research at Genentech, where she works to increase focus on patient centricity and equity effects in health economics and outcomes research and health technology assessment. Her background includes both US and global work to inform HTA and reimbursement, as well as public health intervention design. And finally, Dr. Shanur Ismail comes to us from the Public Health Agency of Canada, where she's the medical lead for the National Advisory Committee on Immunizations Guidance on the use of COVID-19 vaccines. She led the development of a framework for the integration of ethics, equity, feasibility, and acceptability considerations in national immunization recommendations. Her article, Navigating Inequities, a Roadmap Out of the Pandemic, was recently published in BMJ Global Health. So welcome to all our panelists, and we'll have you come back after a couple of slides to set the stage here. So if we get to the next slide. So you could probably ask each of us, and we'd probably have a different definition of equity. But we think the definition here from the Robert Wood Johnson Foundation is a pretty simple and direct one. They say that health equity means that everyone has a fair and just opportunity to be as healthy as possible. And they go on to note that this requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So a goal I think we can all strive for. And I don't think I need to go into all of the larger things that have been happening in the world that have led to us to focus on equity today. But I think it's a long time coming, and hopefully this focus will be maintained, long after some of those factors have ceased to be so prominent in the media. you go to the next slide, please? So recognizing this, recently when IVI promulgated its principles for value assessment, one of the 9 principles was to support health equity. And so we see this really as something that needs to run throughout value assessment, health technology assessment work, not something that we can deal with and be once and done. It's going to be an ongoing effort, I think, to deal with this in better ways in our field. If you go to the next slide. So what are some of the things that are supporting fuller consideration of equity and value assessment? Why do we need to be concerned about this? Well, for one thing, we know that the patient perspective is often lacking in value assessment and health technology assessments. And further, we know that even when we do have data on patients, it typically doesn't reflect the patient diversity of the underlying population. So whether it's from randomized trials or prospective observational studies, we often have problems getting representative samples. And traditional cost effectiveness analysis usually doesn't assess whether treatments are likely to continue or even exacerbate current inequities in the healthcare system. Economic analysis has tended to be pretty agnostic to what happens in terms of inequity. And at the same time, we know that we're seeing some existing and emerging methods that are starting to be put into use that could improve patient representativeness in research and could focus people's attention on issues around equity in these types of assessments. And so today we want to talk about some of those existing and emerging methods and some of the challenges and potential solutions that these methods might give us in terms of being able to pay attention to equity in health technology assessment. So with that, I'll turn it over now to Lisa Prosser to talk a little bit about the history of equity in economic analysis. Lisa?
Great, terrific. So, thanks so much, Rick. And just want to say it's a treat to be here, to be a part of this conversation on exciting new approaches to incorporate equity considerations into cost-effectiveness analysis. But before we launch into the specific methods, it seems it would be useful to take a brief historical tour of how we got here. Next slide, please. So for many of us who are practitioners of cost-effectiveness analysis, I think we often feel like the quote on this slide, that often I've come to the end of my presentations or end of my papers with a discussion of the many equity issues that are important to consider in a larger decision-making framework, but have not been addressed specifically by the cost-effectiveness analysis being presented at hand. And as we typically think about cost-effectiveness analysis, that in the context of health technology assessment frameworks, CEA is only one input into a decision-making framework, and equity and other considerations will be considered in that larger context. But there have been a number of advances, and over the years, many, I would say, attempts to incorporate equity considerations directly into the cost-effectiveness analysis framework, and exciting to talk about some of the new methods here today. Next slide, please. So in looking back over the past 20 years or so, I conceptualize the approaches that have been used to consider equity in the context of CEA into kind of 3 major categories. First, approaches, you can go back to the previous slide, thanks. First, approaches that address the limitations of the quality, of which we know there are many. A second group of approaches that have proposed alternative frameworks, potentially moving away from the conventional incremental cost effectiveness ratio. And then most recently, in the methods that we'll be focusing on today, formal methods to incorporate equity considerations into a CEA in an equity informative cost effectiveness analysis. So next slide, please. And so I think, the question is, why have there been so many attempts to do this? And I think that, while the core tenet is that, we do acknowledge that cost effectiveness analysis is only one input into a policy decision, and that other factors, can and should and always are considered in the broader decision-making framework for any policy or clinical recommendation. That at the same time, we recognize that there are societal preferences for characteristics either of the population being treated or the treatment itself that are not reflected in the incremental cost effectiveness ratio. And without being able to adjust for those, it feels like there's something missing, that there's more that we could contribute to the policy conversation. And so looking at this slide, just some of the ethical and distributive considerations that have been considered over time, including health inequalities, either by race or sex or social class, considerations for the sickest or worst off, thinking about the rule of rescue, children. How do we try to capture and reflect the ability for children to have an opportunity for growth and development in the cost effectiveness framework? We really can't do that right now. I'm thinking about different considerations for older individuals, spillover effects, both non-health and health, as well as caregiver and larger family considerations. And I'm not sure if you can see it on your screen, but the very last bullet here is cut off, but that reads large benefits to few versus smaller benefits to many, again, referencing one of the major limitations to the quality adjusted life year, which is that that we really, in some senses, do not believe that equality is equality. And I'll come back to this when we talk about some of the approaches on the next slide. So next slide, please. So, and then just to start by like the larger context Rick, I like how you frame that in terms of the goals of the RWJ Foundation. Another concept that we often think of when we think about incorporating equity considerations is that the justness of a society can be measured by how well it treats its least well-off members. And I think that is really what is driving all of the approaches that have been developed in this space here. So I'm just going to run through on this slide just a couple of the approaches that have been used in the past. First, starting on the left-hand side, recognition that not all quality adjusted life years are equal. And again, here, this is the concept that, if we're talking about life-saving treatments, that we know that the public does not value those the same as, many smaller increments of health gains over many individuals. So thinking about episodes of the flu compared to a cancer treatment, that if we were looking at the same ratio for those, we know where as a society, we would prefer to invest our resources. So there have been a number of attempts, primarily through adjusting for different thresholds. Example, in the UK, NICE has guidance for highly specialized technologies for a number of years now, which allows for a higher threshold of 100,000 pounds per QALY, and as well as a re-weighting of the QALY gains themselves with a factor of 1 to 3, depending on the number of total QALYs gained per person, if it's greater than 10, and then a sliding scale up to 30. And so thinking about 30 quality adjusted life years gained, if we're talking about discounted QALYs, that's essentially a life-saving technology. And prior to this, NICE also made some adjustments to thresholds for categories of patients who did not have access to other treatments. And the first example of this was for the interferon betas for multiple sclerosis, in which the threshold was increased from 30 to 36,000 pounds per QALY, and then a risk sharing scheme was set up to follow the treatment effectiveness over time. In the US, the Institute for Clinical and Economic Review, or ICER, has proposed adjusted thresholds for ultra rare diseases, so with specific sizes of patient populations, first proposed for up to $500,000 per QALY, and then I think now they've settled at a lower but still higher threshold of $200,000 per quality adjusted life year. ICER has also introduced an alternative metric to the QALY, the equal value of life years gained, or EVLYG, again, in an attempt to overcome the limitations of QALYs and as a way to kind of reflect our broader societal preferences for how we would like to invest or allocate our healthcare resources. Then on the right-hand side, thinking kind of more broadly about the decision-making framework, there are a number of examples, and I'm not going to go into these in any detail, of places where we have, where the cost effectiveness ratio has been moved away from, either in part or wholly. One of the first health systems to do this a number of years ago was IQWiG, which really moved away from using the quality adjusted life year in its decision-making around health technologies in Germany. And for multi-criteria decision analysis, this has been proposed in a number of contexts. Here in the States, there's a smart vaccine algorithm, which was developed by the Institute of Medicine. And for that kind of broader decision-making approach, they've actually included different elements of the cost effectiveness ratio. So costs and health gains are included as part of the framework. The ratio itself could also be included in the framework, but using a structured decision-making approach, it's formally integrated into a larger decision-making process. So, but I think the bottom line here is that while there have been a number of approaches that have been proposed and evolution in these approaches, that really nothing has emerged as a gold standard. And I think that reflects that, that there hasn't been anything that has stood out over time as an approach that really can fully reflect equity considerations in a way that is really accounting for our social preferences in terms of cost effectiveness analysis and then resource allocation. Next slide, please. So on the next couple of slides, I'm just going to divert for a moment and then come back to kind of the newer approaches, but to review the results from a recent systematic review. And this study was led by my student, Anton Avancenia, and was recently published in Value in Health. So systematic review of equity informative cost effectiveness analyses. The inclusion criteria included 2 or more alternatives. If the analysis explicitly mentioned equity as a goal for the analysis and applied an equity informative CEA method. So in terms of the number of papers, there are 54 articles identified between 2010 and 2019. And not that there was a limit on before any papers earlier than 2010, but there were none identified before that time. And the great majority of these were published after 2015. So again, important to keep in mind, this is an emerging field and these methods are still evolving. The conditions, about half of the papers focused on primary prevention, cancer, or infectious diseases. Then in terms of the equity or distributional criteria addressed, these are the top 5 in terms of the criteria that were identified in the review. I think really important, especially as we think towards the conversation here today, but how to think about this in a US context, that the by far the most frequent criterion was socioeconomics or social needs, socioeconomic status or social needs. Then race, ethnicity, geography, age, and a few on disease severity. And then there are a handful of others as well. Next slide, please. So in terms of the types of equity informative cost effectiveness analysis that were identified, the majority of them reported equity impact analysis alone. 16 reported an equity impact analysis with financial protection effects. 5 reported equity impact analysis with equity weighting, and then 3 with equity weighting alone. And that there was, not surprisingly, in most of these papers reported a more favorable cost effectiveness ratios with the incorporation of equity considerations into the analysis. So I think just a couple of summary points for the review is that the pace of the applications is increasing, but only a handful have really started to look at some of, I think, the equity criteria that we might be primarily interested here in the US. It's also important to note that one of the themes throughout these papers is that there are methodological challenges, additional complexity to these analyses. There's a lot of data needed that we don't necessarily have available yet, especially in a US context. And another theme is also that these results, similar to conventional CEA results, should again be used as an input into the decision-making process, but not the only input. But I think there's a lot of promise here. It's clear that the pace of publications is increasing, and there's a lot of movement happening in this space. Next slide, please. So in terms of what is available now in terms of moving beyond an ethics-free cost-effectiveness analysis, I think in 2016 there were 2 tutorial papers that came out that provided clear guidance for how to execute an equity-informative cost-effectiveness analysis, extended cost-effectiveness analysis, as well as distributional cost-effectiveness analysis. And then, of course, there's the text that came out from Richard Cookson and his group just last November, which is a crucial addition to the field. It would end by saying, like, there are many potential applications in the US context, and I look forward to talking about those in more detail during this conversation. I think it's very important to note that there are limited examples in the US setting today. There were only 2 that were identified in our review, and many challenges, although very exciting that these methods are now available, and looking forward to hearing the other speakers and the conversation. I'll turn it back to you, Rick.
Thanks, Lisa. And that's, I think, a perfect segue into Stacy's presentation, which will be on distributional cost effectiveness analysis. Before that, I just wanted to remind people that if you have any questions for our speakers, please type those in using the Q&A function on your Zoom screen. And now I'll turn it over to Stacy.
Great, thank you, Rick. And I'm so glad that Lisa gave such a great background. It feeds right into, I think, what I'll be discussing today, which is our US application of distributional cost effectiveness analysis to the US setting. And because that's a mouthful, I'm just going to call it DCEA moving forward. And I just quickly want to thank my fellow researchers, Danny, Carmen, and Robert Schultz. And I also want to thank Richard Cookson, who's been advising on this work. Next slide, please, Judy. So Lisa did some of this for me, but I just wanted to quickly give a brief introduction to what DCEA is. So we use conventional cost effectiveness analysis because we operate under scarcity. We need to think about how we can maximize health given opportunity costs under a fixed budget. But the concept of DCEA has to do with the fact that the choices that we make in healthcare can either hardwire or they can improve upon the existing inequalities that we see today. And interestingly, one of the things that DCA makes us realize and quantify is that who gains and who loses when we have a cost increasing health program depends on a variety of factors. Not only the efficacy of the intervention and the uptake of the intervention, but our underlying health risks, our capacity to benefit, but also, and crucially important, is who's going to bear those opportunity costs of the money foregone because you're funding this. So we move to the next slide, please, Judy. We recently completed a pilot application of DCEA to the US context, and we did it to investigate how reimbursement decisions for inpatient COVID-19 treatments would impact underlying health inequities. For today, I'm not going to run through exactly how to do a DCEA. There are some fantastic tutorials and presentation sessions and a fantastic book that Lisa has highlighted. Instead, what I'd like to do is think about what we learned when we did our process about what's available today for us to use. What would be some of those immediate next steps types of research we might need to do? And then what are some of the larger or loftier challenges? But at a high level, we followed 4 key steps when we did our own DCEA. The first step, the hardest step, and the longest step was getting the right data. We have to take, when we think about a CEA, you're saying, I want to look at an average patient indication X. Well, the DCEA says, take a step back. I want you to understand your entire population that you cover, and I want you to think about what health inequities or disparities look like today. Then you think about, are there key subpopulations, or how do I break this into groups that help me to understand not only how does health vary today, but how could health vary with this intervention or disease? We then modify our cost effectiveness to be able to run through different subgroups. We then quantify the effects of those subgroups, and then we have to think about what that means overall for our population. A DCEA goes on top of your CEA, and the actual mechanics and the calculations themselves, and I think Lisa mentioned this, are not the barrier. It's really step 1 and step 4 that we need to think about for application to the US context. Next slide, please. So the first thing that we had to do is say, what does health look like in the United States today before we consider COVID effects? And we had to think about not only kind of length of life, but quality of life. And we had to think about how do we break apart our population to represent different vulnerable subgroups. Because we were looking at COVID, we knew we had to look at different racial and ethnic categories because of everything that we've seen about the alarming and disparate effects across individuals that are Black, non-Hispanic, and Hispanic. So we have that segregation. But then we had to think about what makes individuals more vulnerable, what really drives their health outcomes. And there's some fantastic work that's been done in the States through the county health rankings model. And they show that about 20% of what happens to us is driven by access to high quality care and treatment. But the rest of it really comes down to root causes, social determinants of health. So even though we saw the manifestation of differences across different racial and ethnic categories, a lot of what was happening was being driven by root causes. So when we see DCA applied, typically we'll look at subgroups based on things that are linked to deprivation indices. We ended up using information on something called the Social Vulnerability Index. It's a county level indicator that covers things such as environmental factors, socioeconomic, broader elements of race, including ability to speak English language, transportation, et cetera. And so what we first did is we took a lot of county level data spanning CDC Wonder, American Community Survey, and we calculated for every single county, what does life expectancy, level of disability, and disability-free life expectancy look like in the US today? And what I'd like to highlight for this chart is as we saw that individuals had increasing social vulnerability, which is made up of a host of factors, including geography, that before we even consider COVID effects, we see a large difference in our ability to benefit, right? So even if we only get 2 QALYs from your intervention, if I'm living 10 years less than someone else, I have a larger benefit. So this is just an initial depiction of some of the disability-free life year data that we saw. I would like to note, and I'll get into this later, we did encounter missingness and suppression. So for example, we capture 31 racial and ethnic categories in our death data, but we were only able to find somewhat reliable data for disability as well as mortality for 3 of those. So a lot of statistical work is needed to fill those gaps. Additionally, we had a lot of lost information and suppression for racially homogeneous counties and small counties. Let's go to the next slide, please. So once we had a complete picture of what the US looked like before COVID, we had to think about how do I actually understand how either COVID or COVID treatments may have different effects in these populations. Unfortunately, I couldn't find a single RCT that actually looked at populations to find not only by race, ethnicity, but root causes and how we would see actual treatment effects change. But we did find real world evidence. There was a host of studies, many of them nationally representative, that showed that as our level of social vulnerability increases, we have a noted statistically significant increase in the likelihood of getting COVID and the likelihood of dying from COVID. So the bottom left here, what I've done is just showed you, even though we already know there are differences in baseline health, where based on my level of social vulnerability and where I live, I am more or less likely to live longer or have a different level of disability. We also found that we had higher COVID risks as we moved into these more vulnerable populations. What the right-hand side shows you is we adjusted our model to understand differences in baseline risks based on level of social vulnerability. So even if we didn't have our perfect treatment data, we were able to adjust for the fact that some populations are more likely to be hospitalized and more likely to die. And what we can see here is we have more social vulnerability as we go from the left to the right. And individuals that were more socially vulnerable had a larger benefit from COVID-19 treatments. And so Judy, if you can click forward, I think there's an animation there. And I think an important point to make here is even if we don't get to the point where RCTs always have subgroups where we can understand some of these root causes, number one, just understanding the differences in baseline health today. And number two, any real world data on how our baseline risks for disease might change based on these root causes still enables us to understand important differences within a DCEA. All right, next slide, please. I'm going to skip step 3, which is quantification, because there were really no US issues with us rolling up some of the subgroups. If you read Richard's fantastic book, you can do that. But at the end, we need to say, well, some people are going to win and some people are going to lose, and we consider both the positive effects of funding a treatment, but the opportunity cost of that money foregone. So what we've done here is we're trying to depict that trade-off between equity and efficiency a little bit more clearly. This is called an equity impact plane. So what we see here on the y-axis is the output of our conventional cost effectiveness study. What is our net monetary benefit? What we see on the x-axis is the output of our DCEA. So what I had simply done is just ran all of our subgroup data through a social welfare function, but we also could have estimated this via first order stochastic dominance and Pareto dominance because we didn't have a lot of trade-offs. The key thing to take away here is that we were able to show that our intervention, number one, was cost effective, but number two, we also showed that it had a positive impact on health equity, given the fact that the opportunity cost trade-offs were less than the larger benefits for the more socially vulnerable groups. Next slide, please, Judy. So what I've done here is just kind of layered on how we were able to do a DCEA the first time through. Number one, we were able to use data, US panel data linked through a FIPS code to create an overview of what health inequalities look like today. We had real world evidence related to a deprivation index that allowed us to model differences in risks. We rolled everything up and it was a pretty simple trade-off because we only had one group that didn't benefit as much, the group that had the highest level of life expectancy, but overall we had such a net positive impact that we had actually a better allocation of disability-free and quality-adjusted life years. But as we move into diseases where there's going to be people that have much larger gains and much bigger losses, we are going to have to advance these methods. So Judy, if you can click forward. So like any type of model or like cost effectiveness, what DCEA seeks to do, it seeks to synthesize a bunch of disparate data and help us quantify uncertainty. And it does that with the objective of understanding equity impacts. So as we improve upon our ability to have representative data, our ability to quantify uncertainty, DCEA will only get better. So if I were to say, what are the things we should do next? Number one, we have to address some of that missingness that I mentioned. Small counties, how do you understand racial and ethnic differences in racially homogeneous counties? And how do I fill the gaps for up to those 31 racial and ethnic categories? So we'll have to work on how do we improve upon the data that we collect today. The next thing that I mentioned is we were very lucky that there was a bolus of research with COVID about real world outcomes based on vulnerability. But when we do real world evidence studies, let's not just look at how inequalities manifest, try to ensure that you're understanding how some of these root causes, these deprivation concepts, socioeconomic status, environmental factors, try to get richer so we can actually think not only of what we're seeing, but why we're seeing it. And then at the end, we could not find any data on US preferences for inequality aversion. We ended up using some data that had been created in the UK. But this really speaks to, I think, what was shown at the first webinar, which is at some point, once we quantify, the question comes, what do we do about this? What is that intersection of health equity and value? One more click, please, Judy. Then I do think there are some loftier challenges if we start to think about this informing real world decision making beyond just having one more data point. We have overall limitations with quality, but in the United States, we do not have good quality data based on nuanced geography, different races and ethnicities, as well as social vulnerability. We used a mapping algorithm based on the SAMDM tutorial. I'm not sure if it's feasible for us to have actual RCT data at the time of launch to go beyond scenario planning to understand if a treatment brings a unique effect. I think that has to do with inclusive clinical trials in that avenue. And then this bottom right is really, I think, what was tackled at webinar 1, which is how do we actually value what we see? I have one last slide, and I just want to reinforce, and I think that Lisa hit on this as well, this is a very important, and I would say an exciting time for the field of health equity research. We're starting to see some movement in being able to quantify equity implications, actually asking about equity implications. So we have a new special interest group that was created via ISPOR, the International Society for Pharmacoeconomics and Outcomes Research. This slide shows our mission and our goals, but at a high level, we want to have the ability for us to share learnings, pilot new methods across geographies, work on data enrichment collaboratively. So if anyone found this interesting, or if you have questions, you have my email address below. And if anyone's interested in learning about the SIG, or if you're attending today because you like this sort of research, please feel free to email me or to email the alias below. But thanks very much.
Thanks, Stacy. And I think it's important and great that we're going to have that special interest group to help continue this work going forward and disseminate it further. So I'm going to turn it over to Shainur next to talk about another COVID-19 equity application here around vaccines. Before I do that, I will remind you that after this, we'll be having a series of questions. And so if you have any questions for our speakers, please type those into the Q&A section. Shainur?
Thank you. Thank you so much, Rick. And thank you so much for inviting me. It's a real honor to be part of such an important initiative. As Stacy mentioned, it's a critical time in our journey through this pandemic that has magnified inequities that have really always existed. The virus that causes COVID-19 is new, but inequities certainly are not. So we have an opportunity now to not only slow the spread of the virus, but also to slow the spread of inequities. You know, we've kind of come to a fork in the road of our journey where we have a choice to go back to the old normal, or we can choose to learn some lessons from this pandemic and go a different route. And as Yogi Berra has said, when you come to a fork in the road, take it. So in the next few minutes, I'd like to present you with an equity tool that we used as a roadmap to guide us to a more equitable, just future. Next slide, please. So during this presentation, I'd like to take you through our journey by providing the background to the development of the equity matrix, and then presenting the tool in the context of our broader framework, and finally showing you how we've applied the equity matrix to Canada's recommendations on COVID-19 vaccines. Next slide, please. So our journey began in 2016 with the National Advisory Committee on Immunization, or NACI. And NACI is a group of experts that develop vaccine recommendations in Canada, like ACIP in the United States. So for over 50 years, groups like NACI have always considered factors like the burden of disease and vaccine characteristics like effectiveness and safety. But in 2016, NACI's mandate was expanded to include critical factors like ethics, equity, feasibility, and acceptability of their recommendations. But there was no systematic way to incorporate these factors into evidence-informed decision-making. And so we conceived a framework. Next slide, please. So this is a busy slide, but it shows you that the labor and delivery of the framework was long and busy. It took 5 years of environmental scans, extensive consultations with various groups, surveys of stakeholders, the general public and providers, and literature reviews. And we found that the resources and time taken to develop the tools have saved us resources and time to implement it. And that's been really important to ensuring that we have timely recommendations, which are urgently needed in a pandemic. So in 2018, we piloted the framework. We received positive feedback from our stakeholders. And then finally, in 2020, the IFA framework was officially born. Next slide, please. So this was just in the nick of time. The framework was published in August 2020, which was 5 months after the pandemic was declared by the WHO and 4 months before the first COVID-19 vaccine was authorized. And we've seen through this pandemic that issues related to ethics, equity, feasibility, and acceptability have really been paramount to consider, not only with respect to guidance on COVID vaccines, but with so many other issues. So this framework is meant to enable the systematic and comprehensive examination of these issues in a timely and transparent way. So in order to do this, the framework includes evidence-informed tools like ethical filters and an equity matrix that were developed to help with the assessment. And NACI has been using all of these tools to develop evidence-informed recommendations with the goal of ethical, equitable allocation of limited supplies of COVID-19 vaccines. Next slide, please. So before I present the equity matrix, I'd like to show you the ethics filter because it demonstrates how everything sort of fits together. And the purpose of the ethics filter is to filter recommendations to ensure that they uphold and integrate the core ethical dimensions of respect for persons and communities, minimizing the risk of harm versus benefits, justice, and trust. And the second column of the filter describes each of these ethical dimensions. The third column is a list of questions that NACI asks when making a recommendation to make sure that the core ethical dimensions are addressed as best as possible. And the last column provides tools to help with this. So for example, to uphold the principle of respect for persons and communities, NACI ensures that all of the evidence and rationale behind its recommendations are summarized transparently in publicly available guidance. It also applies an acceptability matrix that we have developed to consider the values and preferences of persons and communities, including the general population as well as high-risk groups. For example, for the COVID-19 guidance, we conducted stakeholder surveys to inform guidance on the prioritization of groups for vaccination. And we also looked at various surveys to determine the level of demand or acceptability for the vaccine in different subgroups. And to ensure that the recommendations uphold the principle of justice with the socially just distribution of limited resources, we use the equity matrix, which is on the next slide. So here's the equity matrix. We developed this tool because we felt that using a single vision equity lens to consider some inequities some of the time without understanding why they exist and how they intersect with other factors can really lead to policies and programs that blindly deepen disparities and further stigmatize and discriminate. So the first column of this tool sheds light on a spectrum of health inequities that often intersect to exacerbate inequities. The second column investigates the complex reasons behind these inequities, including differences in exposure, differences in disease severity, and differences in access to healthcare. And the third column proposes fair, respectful interventions to address the inequity and improve access. The spectrum of factors included in the first column of this matrix was adapted from the Progress Plus model of health determinants. And the red text shows how we expanded the categories and addressed important health equity factors that were not explicitly included. And by including them explicitly in our matrix, we can ensure that these factors are unequivocally considered. So we've used this framework to guide a rapid review of risk factors for severe COVID disease. And the review shed light on independent biological risk factors for severe outcomes of COVID, like advancing age, as well as independent social risk factors, such as racialization and low income. It identified factors where evidence exists, as well as potential risk factors where evidence was sparse. But if we don't have a framework like this, then there's a risk of disregarding potential inequities because of the absence of disaggregated data. So using the equity matrix to recognize that inequities may exist where evidence does not yet exist is really important for ethically just interventions. It also helps guide surveillance and research in order to unveil epidemiological uncertainties and risk factors of novel diseases like COVID-19. Next slide, please. So this is an excerpt of the equity matrix applied to COVID-19 that looks at racialization as a factor contributing to inequity. We populated it with emerging evidence, expert and stakeholder input, and previous research and evidence from other vaccine programs. So for example, we have seen evidence of higher rates of COVID-19 in ethnoculturally diverse neighborhoods. In some places in Canada, areas with the highest proportion of visible minorities had a mortality rate 2 times higher than those with the lowest proportion of visible minorities. Now, the second column of the equity matrix outlines reasons why this inequity may exist. So for example, we know that even in countries with universal healthcare, there is evidence on differential access to quality healthcare among racialized populations. And these populations have also been subjected to differential exposure to the SARS-CoV-2 virus because of disproportionate representation in precarious jobs in essential services like food and healthcare. The inability to physically distance due to congregate living and work settings perpetuates transmission of infection within communities, as does a lack of personal protective equipment. We also know that vaccine intention and coverage is lower in many of these groups. So for example, Canadian survey data has shown us that vaccine hesitancy for COVID-19 vaccines is almost double among Black Canadians and among those in the lowest income groups. Now, at the bottom of column 2 in italics, you'll see that the matrix recognizes that there are multiple possible intersections between racialization and other factors like socioeconomic status, place of residence, for example, due to multi-generational living, and occupation. And recognizing the intersectionality of the determinants of health is critical for change. And speaking of change, the third column proposes some practical multi-sector interventions that don't ignore the diversity and disparities or the historical and structural basis of some of these disparities. Because applying an equity lens to bring inequities into focus without a vision to alleviate them is short-sighted. Next slide, please. So our journey with our roadmap led us to propose this framework for the ethical, equitable allocation of limited COVID-19 vaccine supplies in Canada. Now, the funny looking thing on the left is supposed to be a vaccine syringe. I'm not sure if you can see it, but at the bottom of the syringe, it shows you the underlying principles for prioritizing populations. Now, these were based on a risk analysis of those most at risk of severe disease and exposure, in addition to issues related to vaccine characteristics, supply, and epidemic conditions. But underlying the entire framework, in the green at the bottom of the figure, are the foundational ethical elements guided by our equity matrix and other tools to ensure that efforts are made to increase access to reduce health inequities without further stigmatization or discrimination, and to engage systematically marginalized and racialized populations. So with this as the foundation, when you get to the top of the figure with the 3 pill bottles, I'm not sure if you can tell they're pill bottles, you might need to use your imagination. Anyways, the pill bottles at the top show the key populations prioritized for initial vaccines. And they were based on an analysis of the full spectrum of inequities and their intersections. So I hope that through our journey, you can see that the equity matrix, though it was initially developed for vaccine guidance, can be applied across a broad spectrum of interventions. It can be applied both within countries and between countries, so that scarce health resources are effectively distributed based on a gradient of risk rather than a gradient of wealth. Next slide, please. So we're at this fork in the road, and I hope we can choose to pick up this opportunity, learn from this pandemic, and use whatever tools we have as a roadmap to a more equitable, just future. Because diversity is not a reason to put up walls, but embracing diversity is the key to open doors. So I'd like to thank IVI, everyone involved in our journey, and thank you all very much for listening. Thank you.
Thank you, Shanur. That was a great presentation. Now I'd like to ask all of our panelists to come back on screen for our discussion, and I'll remind any listeners that feel free to type in your questions in the Q&A section of the screen. I'd like to ask if any of you have questions for each other, but first I wanted to get in a question about, we heard about some data gaps. It seems like there's some real data gaps here, especially in the US. Methods, may be there, but are there still gaps in methods? Is it really an issue around translation of the methods and the data into actionable assessments that decision makers or policymakers could use? Or is it really lack of demand from policymakers, decision makers? So what do you see personally as the biggest hurdles to getting this type of analysis actually used in practice? No one wants to take that one?
I'm happy to jump in. So I strongly believe that it's the last item that you mentioned, that lack of demand. And I think the most pressing question, and very eager to hear others' thoughts on this on the panel here today, but who is the decision maker that will utilize this information? The biggest challenge is our fragmented healthcare system, that the same challenges that we have for uptake and use of conventional cost effectiveness analysis are the same, and even more so for any type of equity informative cost effectiveness analysis, that because it's very easy to see who the user would be in other countries that have national health systems. Here in the United States, things are set up so differently that it is really hard to conceptualize who the decision maker would be that would want to utilize these data, although I remain hopeful always. But when we think about, what's the closest that we have to a single payer here in the United States, the obvious entities that come to mind are Medicare and Medicaid. And that becomes additionally challenging because, well, Medicare, I think we'll leave aside for now, because we already have segmented the population. So Medicare is only older individuals. Medicaid, we've already sliced off the segment of the population that has the higher or highest social needs as determined by social determinants of health. And so how do you, then it's back to the methods, how do you think applying these methods when you're no longer looking at the entire population, you're only looking at a small segment of the population. And on top of that, I'll add in the very fragmented nature of the Medicaid system itself, that we talk about Medicaid as if it's one system, but it's not. It's 51 systems or potentially more. And when we think about if a state level decision maker might be a consumer for this type of information, then it comes back to kind of what does the US public really have in terms of preferences for inequality? And that is going to differ substantially. There was a terrific article that just came out yesterday in the New England Journal by Sarah Rosenbaum on health equity and Medicaid transformation. And she has this great map that shows, the different uptake and the different level of benefits, leaving aside, which states chose to adopt Medicaid expansion under the ACA, which ones didn't. So I really think we're talking state level decisions, maybe regionally, but that's where we need to start in terms of thinking about who's the decision maker.
Thanks.
I'm going to agree with Lisa wholeheartedly. I do think there's a little bit of work to do for the methods, but there's always work to do for modeling methods, right? We can always fix the way we project all sorts of data. So I think the biggest issue is when we don't have a single payer, number one, that typically cares about managing the health of a population from when they're born to when they pass away, as well as managing the health of a population across different geographies. Even when we did our work, one of the hardest things that we really chewed on before we got to the hard data work was, how do we make a research question that's applicable in the US? And so for COVID, it worked just because of the age of the patients and it was more relevant. But I think a lot of the points that came up at your first webinar are really the biggest issue. Is we can easily start doing more of these, filling data gaps, but even if the methods are ready for prime time, how are we actually going to use this, and who's the stakeholder?
I'll just add, I can't speak to the US healthcare system, but I think one of the biggest hurdles between, for Canada or the United States or anywhere else in the world for that matter is the collection of data, because without disaggregated data, we really turn a blind eye to inequities and we make assumptions about populations or we exclude them. So we need data on a spectrum of factors that contribute to inequities, how they intersect, understand why they exist, and how to address them. Because I think we can all acknowledge that inequities must be taken into account, but there's no real scientific consensus on how to effectively take action to reduce them. There's limited evidence on the impact of intersectoral action on health inequity, in health equity, but that's not because of a lack of effect. It's because of a lack of rigor in the evaluation of these interventions. Because if you think about it, it's really unethical to conduct a randomized controlled trial with a control group that doesn't receive a proven intervention. So we need well-conducted, scientifically rigorous, ethical studies of interventions evaluating the impacts on health equity. And we also need to include diverse groups in clinical trials in an ethically sound way. There was a study that was published in 2020 investigating clinical trials of COVID-19 treatments, which found that a third of them did not report ethno-racial data, and Black patients were underrepresented. So we've seen evidence through survey data that exclusions in vaccine clinical trials, for example, contributes to distrust and vaccine hesitancy. So lack of data is a hurdle. but it must be gathered in a respectful and ethical way.
Thanks. And then a follow-up to you. This came from the audience, a follow-up to Lisa's point with respect to implementation. But they were asking, what's the role of CADIF in the provinces in Canada in using the matrix that you were discussing?
You know, that's an interesting question. As I mentioned, the tools were just published recently in August 2020. And we've just, we piloted them in 2018. We've been rolling it out. We've been using them throughout our COVID-19 vaccine guidance. I don't know that CADIF is actually using any of these tools. They're probably relatively new for them.
Thanks. Another question we got is, and this was kind of related to something I was thinking of when I saw your equity impact plane, Stacy, is, one question I had was, what do you do about interventions that fall into one of those mixed categories? How do we think about decisions around that? But we also had a question that said, for those interventions that may reduce health inequities, should we be rewarding them with higher value-based prices because of that?
Yeah, those are two big questions. So I think part of the answer comes down to we need more information on what we value, right? There's not we couldn't find a single US study on what is our preference for inequality aversion. As well, I think it needs to not just come from payers, right? And I think it'd be great for something like, the p-value group, right? They're doing all these great MCDA studies to say, how does value change across stakeholders? I'd love to see that for equity. In terms of how we actually put kind of threshold weighting or quality weighting, we used a social welfare function, so we kind of got to get around a little bit of that, and we said this is some missingness of data. I do think, number one, we can just start showing it in a disaggregated fashion and then saying, when you're making a decision, instead of having, two experts say, well, I think it makes things worse, they can actually look at those decisions and have more information to guide them, even if it's done in an MCDA or more of kind of a qualitative framework. I do think we can watch what happens in other countries. I believe there's a nice methods review going on right now, considering things like quality weighting, threshold weighting. But it's not just about giving more money because you've done something. It's about realizing, where are we systemically underinvesting? What populations, and maybe making a signal, how do we value innovations in this area? How do we do systematically underinvest in interventions and treatments that help the populations most in need? So I don't know in the US that we'll ever have like a willingness to pay multiplier, or if we should. But I think the most important step one is just being very clear, are there trade-offs? And then opening a dialogue about, are we going to make another program for this to have an extra effect because we've had a negative? But in exactly how we value it in terms of dollars and cents, I think we're a few years or more away from figuring that out.
Got it. Yeah, I often wonder what the inequality aversion in the U.S. would look like. I think it could be quite a bit different than what we see in other countries.
Yep. Lisa's got a point, I think.
Can I add to that? I just wanted to add that I think it's important to also to recognize that all inequity is not likely to be valued the same here, especially in the US context. And so, much of the work that's been done in other countries, and in Stacy, the example that you gave is really focusing on social vulnerability and inequality with respect to social determinants of health. And, that's where I agree with you, Rick, like we need to do collect the evidence to see kind of what the inequality aversion is here. But I do think if we're talking about, questions around health inequity and people who are disadvantaged in terms of health, in terms of rare conditions or, very severe states of health, that is one place I think where, there could be an argument made. I think the question still is, who is the stakeholder or the consumer of this information? But we certainly have, from one perspective, collectively, we have decided that providing health insurance is not a collective value for our country. Yet in some states it is, like Massachusetts. And so I do think there are places where at the local level, that this information will be highly valued.
Yeah, I think one of my questions was going to be why the U.S. lags behind other countries in this area, but I think you guys have already answered that. I think a big part of it's our fragmented healthcare system. We had a question for Shanur, which was about lack of access to technology. COVID highlighted how disadvantaged those without internet access or smartphones were, and how that could influence access to healthcare, including vaccination. So where would the matrix, in which category would you capture lack of access to technology?
That's really an important issue. And I think, when we're collecting data, we really need to be mindful of the diversity of populations. If you conduct an online survey, you're going to miss marginalized populations that don't have access to a computer or the internet. If you conduct a survey in English, you're going to miss people who don't speak the language. So we really need to find creative ways of accessing diverse populations using both quantitative and qualitative methodologies that are inclusive and respectful. And we need to understand the historical and structural basis of some of these systemic inequities if we want to be able to truly address them. The other issue is, we need to be mindful of numbers to ensure that you're able to analyze the data, to oversample some key populations, which is what we did when we conducted our surveys. We oversampled some key populations like New Canadians, so that we could analyze any statistically significant differences. And within our broader framework, that would fall within our acceptability matrix, where we look at acceptability for an intervention from the perspective of the general population, including high-risk groups, as well as providers and policymakers. And when we did our 5 years of research, we commissioned a systematic review on acceptability literature, and the review identified over 100 factors linked to vaccine acceptability, but we were able to group them into 4 main categories that could apply to any intervention, not just vaccination. So perceptions of the intervention, like perceptions of how effective or safe it is, perceptions of the disease, so your personal risk of getting the disease and the severity of the disease, and the process to get the intervention. So how hard is it to access? What's the cost? How long will it take to get it? And then, of course, various individual factors like personal beliefs and values, experiences and trust in healthcare providers and the system, trust in experts, trust in industry, as well as social norms, pressures, and the media. So those 4 broad categories of acceptability are considered from the perspective of the general public, and including high-risk groups, providers, and policymakers. And that's where those kinds of considerations would be taken into account.
Great, thanks. I was going to ask about the acceptability matrix and what that included in it. We also had a question, we kind of touched on this, but I think we could go into more detail on how could this research and methods be used by payers in the US? And I know there are problems with our fragmented system, but to the extent that payers did want to look at some of these issues, are we there yet, or are they going to have to wait a little while for us to be able to supply what they need?
Well, clearly a rate limiting step is the absence of any information on inequality aversion for the US. And so, because I don't think we can make any kind of reasonable inference that, what has been collected in the UK or Canada or other countries would apply here. So I think that is a rate limiting step, but that I think there is a growing body of work, and I would put the fields in the category of emerging, and that there's a lot of work happening right now, and that we'll be seeing a lot more in the coming years. And I guess I would add to that kind of a call to action for anybody who's part of this conversation today, that I do think, yes, the biggest challenge is who's the stakeholder, but we are really limited by the data that we have. And as Stacey highlighted in her presentation, we don't even really have good national data on health utilities to generate qualities on a national level. And so, if we can think collectively about how to come together as a health economics community to really, either work to get these measures incorporated into national data sets, or create other networks where we can start to collect these data. I would say that, that BQ5D was part of MAPS, the Medical Expenditure Panel Survey, part of the National Health Interview Survey for a few waves, and then they took it out. And so that was a great source of data, but no longer available to us. What we've been coming up against, and I think, this kind of work would really inform both our conventional cost-effective analysis as well as any kind of equity informative CEA. What we've been coming up against in looking at measuring spillover effects to the family is that we have terrible data on even just trying to understand what the financial impact is at the family level. It's just not really collected in any national data set. So for every analysis we do, it's like a primary data collection exercise. Even if there's been a well done RCT that includes an economic evaluation, often they're not including those family level spillover effects, either financial or quality of life or caregiver time. And so really to think collectively as a health economics community about how we can come together to create networks and start collecting those data on a broader basis.
I do think, to take the phrase emerging, I think if a few key studies were completed in the next few years, we could start to do these more routinely while we start to do some of that bigger kind of data enrichment for panel data. I think we were able to capture like 83% of the US population, which seems great, but there was 18% missing. And so I think if we do a few easy steps, easier steps in terms of US inequality aversion, some statistical imputation for the missingness, we can start to do these things more regularly, but then it's really championing an effort to say, whether it's during regulatory, whether it's in our panel data sets, how do we start to collect this more important information? So I think it's definitely emerging. And you can start to do these every day with caveats, but I think for us, we're hoping to address some of those gaps and then to start doing these a bit more regularly. And then from there, think about how do these more large scale, very expensive, long-term data enrichment efforts start to begin.
Yeah, thanks. That's the data gaps, that's been one of the most frustrating things for me trying to do these health technology assessments, because when you engage with patient groups, they will tell you what's important to them. And almost never do you have data on what is really important to patients coming out of clinical trials. And so I think we really do need to do some work to lay that groundwork and get that data in place. So I have a lot more questions. I wanted to get into intersectionality and how we account for different types of equity considerations and make sure we're not double counting. Talking more about who should be responsible for filling some of these data gaps or making sure we're pulling this into practice. But I do see we're getting close to the end of our time. So I wanted to ask if you all had any last thoughts or questions that you wanted to raise that we could think about as we move on from here.
I have a question for
Sure.
the other panelists who are much smarter than me. So maybe you have an answer because I certainly don't. With this pandemic, there's been a lot of talk of global equity, and we've heard that no one is protected unless all of us are protected. And we've in our countries, we've been very fortunate to have a vaccine supply where a majority of the population can have access to vaccines. But the WHO has recently made a call for those countries that have been more fortunate to forego vaccination of some of their populations to provide vaccines to other not so fortunate countries. So I'm wondering, we've talked about equity in terms of our own countries, but how do we incorporate issues of global equity into our analyses?
I'm glad you asked an easy question. I think we saw some good discussions of this, and I apologize, I can't remember the names of the webinars, but they were talking about, making like an advanced entry agreement that talks about a discounted price for some countries if you want to get access at this price in another country, or how you could create a TPP for a vaccine that says, when you hit these things that we will give this level of reimbursement. So I think driving some sort of global collaborative view of what we value, and having countries, which is way above my pay grade and my expertise, talk about saying and negotiating those things. I know maybe starting with something like Gavi, but I think it's refreshing to see that we're having this conversation in the States, but we're so far behind, I think, where we could even be locally. And then the goal is, how do we also remind people that it's bigger than just the US? But I know there were some great initial discussions at the beginning of COVID about how we did this and how we incentivized creating the right vaccines and doing these kind of bilateral agreements. But I really hope we can keep that conversation going to prepare for not only the next pandemic, but other conditions that we see huge inequities across different parts of the world and different levels of development.
Yep. Lots of work still to do. Lisa?
Yeah.
As I say, and I think we have seen, unfortunately, how the US has demonstrated its willingness to engage or not engage in that global conversation very clearly in the last year. And we certainly hope that that will change. But I will end on a positive note by saying that I think it was really important to note that for the very first time that a social justice framework was incorporated into the ACIP decision-making approach, the Advisory Committee for Immunization Practices here in the US, which makes recommendations on behalf of the CDC. Having said that, though, that the prioritization scheme that included those that equity framework was really flat out refused and rejected by some states, and they created their own schemes. And so I think we have to put the U.S. in in an emerging category as well for where it is likely to be in terms of participating in this global health conversation. And I certainly hope we see movement, but it's been very disappointing this year.
That was the positive note?
Oh, sorry, I was going to say, so I do think it was positive that that the CDC did incorporate this into their framework, and they plan to use it going forward. And so there were certainly a number of states that did move forward and adopt that framework. And so I think that is a notable shift, at the national level. So sorry.
No, thanks. And with that, I see we're getting very close to the end. So I want to thank all of our speakers. I want to thank all of you for listening in today. Judy, if you could pull back up the slides. We talked about this being ongoing work and something that will need to continue into the future. And on that note, the third webinar in this equity series that IVI is doing will be coming up on July 14th. And there we'll be looking at walking the talk. How should policy uphold equity in value assessment? So really touching on some of the things we touched on here, but going further into, what are policymakers looking for and what are their roles and responsibilities in this area. And so we hope you'll join us for that. We should have the registration link up on our website sometime very soon. So please look for that. And with that, I will close out and hope you all have a good rest of the day. Thank you.
Thank you. Bye-bye.